Good morning, good afternoon, and good evening to all my friends and colleagues around the world. I welcome you all for another Podina session with us, with a person from Egypt, a friend of ours, Dr. Khaled EKram. Thank you so much, Dr. Khaled, for joining us with this Podina session today.
Thank you very much. My pleasure is mine.
Thank you so much. And before I go ahead with his credentials, I would like to know, Dr. Khaled, that how is the pandemic in Egypt? Now it's treating you at there. How exactly the conditions are now about dentistry and all together?
Actually, is hesitating ups and downs, but we are coping and living with it now, and we are taking our precautions. We are trying to cope with life because it seems like this issue will be a little bit long than what we expect.
So how is it like dentistry is moving? Are the dental clinics are open and we are working back to practice, or it's like an on and off you are practicing now?
Actually, a lot of clinics are back to work, and the number of clinics working are now increasing. And of course, everyone is taking care of himself and taking all the precautions of wearing barriers or extra cleaning or making disinfection. All of the precautions were known to all of us is taken well. But actually, the dental business is going on and it's rising actually nowadays.
So how you take dentistry all together now? Like after this, like what's your experience? How you take up dentistry now? Like how we are going further after this pandemic once it goes off? I think the dentistry will going to change, and especially in terms of the aesthetic dentistry and also in terms of the pain management. And as your specialty is more on the dental radiology, so how exactly you look into it? Because nowadays what we had been doing is we are recommending our patients about more on the extraoral radiology rather than on the intraoral radiology. So, what's your opinion about it?
My opinion about the situation now is that we are heading to a different style of dentistry where patients will prefer smaller, little number of visits compared to the condition before. A lot of services is going to be prepared digitally before going to the treatment inside the patient's mouth to save time and visits. Actually, remote services is going to be used a lot during the coming days. And also the process of pain control and such stuff also should be more developed to decrease the duration of the visits and make the patient more comfortable. This is my opinion actually about the next coming days and time in dentistry.
Okay, so I feel like most of the dentists we all are been practicing probably as on the radiology, and I think radiology is one of the integral part of the dentistry. And even we believe the same that the three-dimensional CBCT scans are very helpful in our routine dental practices as well, especially when I'm an endodontist. So when I'm been doing and also an implantologist, so I always believe that I think CBCT is changing the world, what we used to or what we used to see earlier. So how exactly it will going to help us in the coming future for our new generation dentists who are coming up?
Okay, before like 15 years from now, 15 years ago, the dental radiology was not that into dentistry and interceptive treatments. But now, after the digital dentistry era has begun, dental radiology have become involved in digital practice, like in planning for surgeries, implant planning. Even today, there are some or a lot of researches about computer-guided endodontics, but it's
Yes.
still on the level of making on a samples, not on patients. But I believe shortly is going to be active in patients and going to be used a lot. For example, for me, I was graduated in 2002, and I started my career 18 years ago. Um, before, my job was only seeing the X-ray, taking case histories, and then writing a report about what I see in the X-ray, whether it's an OPJ or a CT or a Cbct afterwards. But now, after that, things have been developing gradually. I learned to make STL conversion to print out models. And then I also learned to make surgical guides. And for learning making surgical guides, I have to learn about occlusion and digital smile designing. In parallel, of course, with orthodontic surgeries and the different resections that we need to do. So now the radiology has become involved in each and every treatment specialty. So things are developing very fast, and now we're in an era that there is specialties are dissolving together. There will be something called an expert digital dentist. We should be aware of most of the specialties to be able to apply it in the digital era. This is my opinion, actually.
It's actually, I believe the same. What you are saying that the three-dimensional, I think, scans and three-dimensional imaging will change the world of dentistry. What we are looking, I think it's a 21st century that we are looking at. That you see well, and then accordingly you can treat well. And I think, as you have said very nicely, that it is not only pertaining to one field; it is actually useful in all the aspects of dentistry. So I think your lecture will be a very great session for all of our listeners, because you will be sharing your views and experiences in application of three-dimension imaging in oral maxillofacial surgery and as well as implantology. So before you go ahead with the search sessions, I would like to share some of his credentials with you all. Dr. Khaled is a professor and EDS certified consultant of oral maxillofacial radiology in Egypt. He is also a DHA certified oral maxillofacial radiology specialist in Dubai, UAE. He was awarded at the master degree MSc and doctor's degree PhD of the oral maxillofacial radiology from the Faculty of Oral and Dental Medicine, Cairo University in 2008 and 2011 respectively. Worked in Cairo University from 2004 till 2016 in different academic degrees until he was assigned as an assistant professor for the oral maxillofacial radiology. He is an active member and an ambassador of DDS, that is the Digital Dentistry Society in United Arab Emirates since 2018. He is an active member of and an instructor in Digital Dental Craftsmen International Education Group, specialized in digital dentistry courses and online lectures. He has been a member of the International Association of the Maxillofacial Radiology and European Association of the Dental Maxillofacial Radiology since 2013 till now. He's one of the pioneers in the especially in the dental radiology and digital dentistry worldwide. Participated in many lectures as an international speaker and many continuous education courses and workshops in Cbct and digital dentistry as a speaker as well as trainer and an instructor. International keynote speaker in many conferences such as EDEC, International Conferences Dubai 2020, Eurodental Conference, Italy 2016, International Dental Global Summit Dubai, UAE, International Conference of Oral and Dental Disease Dubai, Fourth International Symposium of the Oral and Maxillofacial Radiology in Finland, and International Conference of the Digital Dentistry, Cairo, Egypt, in addition to many other national and international conferences. He's participated as a speaker in DGZI implant course and also the MEDS implant diploma, in addition to many continuous education courses in Egyptian public and private universities. I think, sir, this are such a phenomenal person is there with us today, and I think there's a lot of learning that we all are looking forward to it. So, sir, I kindly request you to please take over the session. Thank you so much.
Thank you very much, Dr. Prashant, for the nice introduction. Our lecture today is going to be on the application of Cbct and digital dentistry in dental implantology and different oral maxillofacial surgery types. First, a bit of history about the Cbct. In 1994, Professor Pierluigi Mozzo accomplished his research about the new generation of the Cbct machine. with his research team in Verona University in Italy. In 1996, the first commercially available CBCT machine was released, but it was with a gantry bed, which is a different design than we have today, like standing or sitting positions. And in 2001, the first commercially available CBCT machine was released in the USA market. Later, in 2013, Professor Mutsu won the awards of the annual science festival, which is called Festival della Scienza in Genoa, in Italy. Simply, the CBCT machine depends on a machine with a detector and the X-ray source rotating out the patient's head in 360 degrees to form the data volume of the patient, or the 3D image of the patient. It's very important to go into details about this. So here what happens that the machine rotates around the patient and takes shots in each angle from the 360. Then a group of images translated digitally in the form of DICOM files. These DICOM files are collected together to form the CBCT volume, or the dataset, DICOM dataset volume. It is important to know about the DICOM because the CBCT and even the CT images are in the form of DICOM. DICOM means like a slice or like a capture. So the more the DICOM files or the captures taken, which means that the image we have is carrying more details. And the more the details we have, the better that we can get use of it. And we're going to see this in this lecture later on. It is important to know about the spatial resolution and the contrast resolution. The spatial resolution means that the image components, or the components that are forming the images, are called voxels. The smaller the voxel size, the more the details of the image, and better differentiation between boundaries of structures that are close to each other. So we can see or differentiate between the boundaries of structures close to each other clearly. When we check in any CBCT machine, its catalog, you'll find the voxel sizes range between 75 to 400 microns. Of course, the less the voxel size, the better will be the image. Second is the contrast resolution, or what we call the bit depth. The contrast resolution simply is the ability of the machine to record different values of grayscale. So it's very important to differentiate between different tissues having different grayscale values or different CT numbers. So the ranges in the market for the CBCT is between 12 to 16 bit. And of course, the more the bit number, the better will be the image and the easy differentiation between structures. This function is important when we are evaluating the bone density measurements and the what we call thresholding. I'm going to show the thresholding in details in the next slides. So this is the image of the CBCT. We can see that the CBCT shows the bone and the internal anatomical structure details, as well as the teeth. But there is poor soft tissue details. There is a very important function called thresholding, or what we call segmentation. So thresholding means to try to get rid of some structures and keeping some structures in order to convert the DICOM dataset into what we call STL. This STL is very important because when dealing with the CAD software, we need to have the image in the format of STL, either during the designing of any appliance or any dental products, and also during production like milling or 3D printing. So the ability to convert the DICOM into STL clearly without losing any details, this is very important. And this is the function of the contrast resolution, as I mentioned in the last slide. So First, I'm going to discuss the application of the CBCT as a diagnostic tool. I'm going to pass by it in a short time. First, in implant cases. Implant cases, the CBCT as a diagnostic tool is mandatory to get the bone measurements, the linear measurements, as well as the relative bone density. There was a study made that for evaluating the abundance of asking for CBCTs. They found that 65% of the CBCTs sent for a hospital was for implant site evaluation, while the 35%, the rest of the cases, were sent for other purposes. So primarily CBCT is very important for implant planning. Also, the second abundant purpose is the impaction, to evaluate the impaction cases to see the position of the impacted tooth in relation to the inferior alveolar canal or any vital structure adjacent to the impacted tooth. Also, it's very important in orthodontic and orthographic evaluation to make 3D cephalometric analysis, and also later on is going to be mentioned when going to see that it has a very important role in making orthodontic and orthographic planning, like virtual osteotomies or virtual mandibular or maxillary advancements for making certain appliances. And also it has some benefit that we can compare between the pre-operative and post-operative images for a patient undergoing certain treatment. Also here, it has a great value in periodontal disease and in bone defects. So in this case, for example, there is a bone defect, and it can be evaluated in 3 dimensions, and also virtual treatments can be planned on the CBCT to see the volume of the graft, and later in later stages, this designed volume that compensates the defect can be milled in a certain milling centers to make a custom-made graft. Okay, now we're gonna talk about digital dentistry and how CBCT has an important role in digital dentistry. So the word digital means computer generated, or means including the computer in the treatment plan and designing of any pre-planned procedure. So we have tools for digital dentistry. We have capture tools or acquisition tools, planning and designing tools, and manufacture tools. The capture tools that we have, these are the tools that make data acquisition, such as CBCTs, optical scanners, and digital cameras, as well as facial scanners. Planning and designing tools, it is mainly these softwares used for planning and for CAD designing of different appliances. Manufacture tools is the tools for production of any designed treatment plan, like the milling machines and the 3D printers. It's very important to know what is the format of each acquisition. So for the CBCT, as we discussed earlier, the image format is called DICOM. For the optical scanning, whether intraoral or extraoral, they have a lot of formats, but the most famous one and the most universal one is the STL format. For the images, whether 2D images by cameras or 3D images by facial scanners, we have JPG or OBJ. So for the CBCT scans, it shows the bone details as well as the neighboring anatomical, internal anatomical structures. But we have two main limitations for the CBCT. First is the poor soft tissue details such as the gingiva or the lips or the facial structures of the skin, as well as the metal artifacts occurring due to the presence of metal restoration or implants. And there's another third limitation is the questionable accuracy of the bone density results, because this varies between one machine to another and from one resolution to another. So these are the three main limitations in the CBCT scans that can make us limited in its use to a certain level. But I believe in the future we will have enhanced hardware and software in order to improve such limitations. For the optical scanners, we have the extraoral scanners that scans the patient's model or impression, and we have the intraoral scanners that scans the patient's mouth directly. These scans shows the teeth and the mucosa clearly. But the limitations we have here is the lack of information about the internal anatomical structures and the bone details. So here, what we can see that we don't have a modality that can show all the structures of interest in the patient's oral cavity, because we care about the teeth, the mucosa, and the bone. And from the previous slides, we saw that we don't have a single machine that can get the three all together in one shot. So from here came the value of the digital dentistry. The digital dentistry depends on a concept called the virtual patient or the digital patient. So the concept of the digital patient depends on idea of the virtual patient, where we obtain each structure of interest separately using different capture tool or a diagnostic modality, and then assembling it with images coming from the other capture tool. But here we have to register them in the correct relation. So we can get here the, for example, here this is the CBCT and the stone model. They are in the correct relation. So this will make accomplish the equation that we want to have, which is having all the structures of interest in one shot. Sometimes we need to include the facial profile to the structure mentioned first, what are the mucosa, the bone, and the teeth, for some purposes, like for orthodontic surgery, for example, and for soft tissue prediction. So here, for example, this is my case. This is for me. Here I have the DICOM data or the CT scan, and this is the my optical scans, and this is my photo. Here I integrated all of these images together in one image by special softwares. So here we're going to discuss the applications of the CBCT in digital dentistry. First, the application of the CBCT when we convert the CBCT into STL. Remember, as I mentioned in the beginning, I showed how to convert the CBCT into STL by what we call thresholding. So this is first is the cranial implant. This patient has a defect in the skull, and this defect is corrected on the computer digitally after converting the CBCT into STL. So here we have the cranial defect on your left-hand side, and here on the right-hand side you will find the design of the cranial implant. So this is the video showing the cranial defect, and then a design for the cranial implant, which gonna correct the defects. And this is the CAD/CAM milling of peak cranial implant in the patient's skull to correct the defect. Another case, which is the maxillofacial resection surgical guide. This case, on your left-hand side, you can find the patient here has a tumor or an aggressive cyst causing the resorption as we see here. And you can see here, this is, we draw like a virtual resection guide in order to be 3D printed, to be placed in the patient's mouth during the surgery, so that we can make a resection that covers just the area of interest, which is going to be removed. The coming case is TMJ ankylosis surgical guide. Here, this patient had ankylosis in the TMJ. So you can see in orange here, there is a design for a cutting surgical guide tool. And here, this is the 3D printing of the cutting guide. And here, this is the cutting guide placed in the patient's mouth for the gap arthroplasty in the TMJ. So all of these applications, we see here, we used only the Cbct STL conversion. We didn't use any optical scans or use any photo or something like this. So here, the Cbct was used alone. Then we have the applications of the Cbct in addition to other modalities. And we're here mainly talking about our main topic today, which is the computer-guided implant surgery or digital implantology. So first, we have to know what is a surgical guide. A surgical guide is a digitally designed device used to assist the operator in the preparation for the implant site regarding the drilling position and drilling direction and drilling depth. So why is the surgical guide important? The surgical guide important in order to digitally design or digitally translate or transfer the virtual radiographic treatment planning preoperatively to the correct real surgical position of the implant. So here the surgical guide will guide the drills into the correct position. So if we don't make a surgical guide and the operator is not experienced enough, we can face some problems like what we are seeing here, like an error in the drilling position or error in the drilling direction or error in the drilling depth, which may cause an injury to the infraalveolar canal. So what is the idea of the surgical guide production? The idea of the surgical guide production is that we digitally design the surgical guide in a special planning software. Then it is manufactured using the 3D printer. Then later on, it is 3D printed. Why is the surgical guide a complex procedure? The surgical guide needs to get use of the bone, teeth, and mucosa, as we mentioned in the beginning, that I need the whole three structures to have them together, because we have many types of guides. We have bone-supported surgical guide and tooth-supported surgical guide, as well as mucosa-supported surgical guide. So in each case, we will need at least two of the three structures. Therefore, we need to have what we call the digital patient. Here I'm going to discuss the steps for the implant planning. Implant planning has many steps and should be followed in order. First, the optical scanning of the patient's jaws, the jaw of interest as well as the opposing one in occlusion, and then we make digital wax up on the areas to be replaced or to be restored. Then we make CBCT scanning. After acquiring all of these data, integration or registration of the CBCT of the patient with the digital model of the patient, and the digital model of the patient is together with the digital wax up. And here it is very important that I have small error range in the registration. So here in this case, the error value is 0.052 millimeters. The maximum accepted range of error is 0.35 millimeter, but above this value, it's not accepted. So it's very important that the software that they are using can record the error range of registration between the CBCT and the store model. After we have the CBCT integrated together with the model and the wax up, implant planning is done, and we have to design the surgical guide in 3 dimensions, and then 3D printing of the surgical guide after, and together with insertion of the sleeves. So there is an important consideration here that we must make the treatment plan prosthetic driven, or based on the prosthetic planning. So the prosthetic planning should be done first, which is the digital wax up. So what if we make the implant planning bone driven, that we put the implant regardless of the position of the wax up? In the future, you will find here that the implant planning will cause a problem during making the restoration. So your dental technician will suffer a lot in making the restoration. But in the other case, if we make it prosthetic driven, the planning will be much easier and will have better prosthetic results and aesthetic results. And this protocol is called VIP protocol, or what we call virtual implant prosthetic protocol. So it's very important before doing anything, we must make the optical scan and the virtual wax up. So we have the first reported case is a very simple case. This is a case of missing upper left first molar. Implant planning is done. This is the surgical guide in the patient's mouth. We can see here, this is the CBCT after insertion of the implant. And we can see the CBCT that, of course, the radio-opaque structure here is the implant itself. And this orange structure here shows the planning position. So here we make like a superimposition between the pre-operative planning and the already inserted implant. We find the deviation here is very little. But of course, not all of the cases pass like this, because there is a lot of sources of errors in this procedure. This is another documented case. It's very important because in this case, an immediate temporary restoration is done, or immediate temporization and loading for a single restoration. In this case, this patient is a middle-aged man or having missing upper lateral incisor, and he's medically free. The problem in this, in such cases, that any lost teeth from the aesthetic zone, the patients are having high demand of immediate loading and immediate temporization, because this, of course, is in a critical position. So we have here the steps is a little bit more than we discussed before. First, we have the pre-operative photos, which are the smile photo, the retracted photo, and here the 12 o'clock photo position. Here we make the 2D digital smile design, and we try to integrate the 2D smile design with the optical scans of the patients. Next step, here we make 3D digital smile design, so that here we can wrap the 2D smile design to the models of the patient in order to produce a virtual 3D wax up. So here we reach to the point that we are discussing before. We make the virtual restoration before the implant planning. And here it is based on the facial profile of the patient and the smile of the patient. So here we integrated the Cbct together with the optical scans of the patient and the digital smile planning of the smile makeover of the patient. Here we make the Cbct. We take the measurements for the bone, and here we decide the implant dimensions and the implant type which is going to be used. In this case, the bone was D4, and the D4 bone is not eligible for immediate loading and immediate temporization. So in this case, we had to enhance the bone density, or what we call osteodensification. So a special kit was used called Bursa was used during this procedure as well after making the guided drilling. So here this case was a little bit complicated because we're going to make the surgical guide pilot drilling first, and then we're going to continue with the Bursa to compress the bone and enhance the bone density. Here we make the registration of the Cbct together with the model, and the model, of course, carrying the digital wax up. So here we have the Cbct and the model and the wax up together. Here, as we see on the left, the implant planning here is prosthetically driven. And you can see here on the right the lingual screw channel passing through the lingual surface of the wax up in order to plan for screw retain temporary restoration. So here is the sleeves. In this case, also we had another obstacle, that the mesiodistal dimension of the dentures area was just fitting to the implant size. So in this case, we cannot use the wide sleeves that we used to use in this case. So we used here narrow sleeves. And here we made the surgical guide design, followed by the 3D printing of the surgical guide. After making the design of the surgical guide, also it is possible to have a virtual scan body or a scan abutment to be aligned with the virtual inserted implant. This scan body is very important because the scan body, when imported to any software, CAD software for making restoration, such as ExoCAD or 3Shape, so it is the indicator for the abutment or the tie base of the restoration. So when the stone model or the digital model together with the digital or virtual scan body, here we have a situation as if that the patient already inserted the implant and an impression is taken or intraoral scan is taken and then sent to the lab. So here in the CAD software, here we designed the future immediate temporary restoration based on the position of the virtual scan body, which was originally based on the position of the inserted virtual implant. Then CAD/CAM milling of the restoration. We can see here that all of this is done before even touching the patient or making the surgery. And here, this is the steps of surgery. The guide is going to be inserted in the patient's mouth. And here we can drill through the guides. And then here's the implant insertion. Then after the implant insertion, you can put the abutment and the prefabricated temple restoration, which was fabricated before the procedure. This is on your left-hand side, the post-operative Cbct for the implant inserted. And here we can see the superimposition of the implant over the planning or the virtual planning. You can see here the difference is very little. And here is the immediate temple restoration inserted. This is the video for the whole procedure. Here the Versa kit is placed. This is the fabricated temple restoration. Here is the model, and this is the temporary crown. And this is the surgical guide. And this is the virtual scan body. And here we design the restoration. You can see here can control the screw channel position. Here we made an automatic extraction for the remaining root. Here the surgical guide is placed and the drilling procedure is done. But this is only, as we mentioned, is pilot drilling. And this is the Versa burr to identify the bone. And here, this is the placement of the implants. And here we can find that there is 50 newtons torque. And here the placement of the PMMA temporary abutment and crown in the same visit with the insertion of the implant. So there are some important considerations in the digital dentistry process. First is the teamwork. Teamwork is a mandatory, one of the mandatory key of success for digital dentistry workflow, because as we see here, the radiologist is included in the procedure, the dental technician, the surgeon, the orthodontist, sometimes the periodontist, according to the case. So having a strong teamwork is very important for the success of any dental treatments. Second is the availability of different types of planning and CAD softwares. Because the planning softwares or the CAD softwares, you will never find a software that can cover all the purposes. You can find a software covering the orthodontic purposes, another one for reconstruction and orthodontic cases, and another one for implant cases, another software for the designing of the restorations, and we have a lot. So it's very important to have a large software armamentarium in order to cover all the specialties and purposes. Third is the availability of high quality capture tools for data acquisition. So this means that you should have a high quality Cbct that can have a high contrast and spatial resolution in order to record the data in a good, accurate way with least artifacts and more details. Fourth, the availability of, it should be available of manufactured tools with high accuracy, because the manufactured tools such as like CAD/CAM milling or 3D printing, if it's not accurate, all the effort that you've done is gone. So these production machines should produce tools which is of high accuracy, such that it can translate the treatment plan that you did in the right position. Here I'm going to speak about future expectations for CBCT. First, and it's not an expectation, it has already started, which is the guided root canal treatment. To have like a guide in order to make a minimal access cavity in order to make the endodontic treatment. It started on a research level, but still, up to my knowledge, still not available yet in the market as a commercially available softwares. So, but I think in the near future it's going to be ready. Another expectations based on artificial intelligence and machine learning. The artificial intelligence is the simulation of human intelligence in machines that are programmed to think like human beings and mimic their actions. So this means that we have a concept that is trained to think and act like humans and act like dentists or CAD designers. And artificial intelligence, which is the AI, is now incorporated in a lot of dental uses. Second is the machine learning, which is a variation or an application of the artificial intelligence. It provides systems the ability to automatically learn and improve from experience without being explicitly programmed. This means that when you put a lot of data inside a certain machine, it can act with a knowledge base similar to a clever doctor, but because this is computerized. So for the CBCT, for example, the expectations that, for example, the models of the or the casts can be scanned with CBCT instead of desktop scanners, so that it can get like as accurate as the desktop scanners. But still, of course, this is not in reality available now. Automated registration, as we know, in digital dentistry, we superimpose or register the CBCT over the intraoral or extraoral scan of the patient. Expectations that with one click, software can identify or merge them in the right position automatically. So this is one of the expectations which is expected to be available in the future. Automated diagnosis. For example, of course, all of us studied the maxillofacial lesions, which is huge between the opaque and the lucent and mixed lesions. All of this stuff. Some coming with impacted teeth, some coming without impacted teeth, some coming with congenitally missing teeth. So all of this information, when submitted to the computer, there is a potential that the computer can make automatic differential diagnosis for the imported case based on the knowledge that the human imported to the machine. Thank you very much for being with us in the lecture, and please, I would be glad to answer any questions from your side. Thank you very much.
Well, thank you so much, Dr. Khaled, for such an informative session about the role of CBCT in the field of dentistry and also especially in the field of maxillofacial surgery. So we have some questions for you. There's one question which is like, sir, you talked about the D4 bone, right? And you said one case you showed about the D4 bone and you have used that denture kit. So there is a query like, what is the speed of the denture burrs that we need to be used when you are doing such kind of cases for osseous this thing?
Actually, as you know, I'm not a surgeon. Okay, I'm a dental radiologist, but you have only one available kit which do this function. So and it's only one protocol available on the internet. But the idea of this kit is that it makes like a reverse
Okay.
rotation of the burr,
Yes.
so it compressed the bone rather than making drilling in the bone. So, but it's only one available because it has, I think it has some patency. So you have only one available kit, which is the Densa kit from Bursa company.
Yeah, it's one of the fantastic kits. Even we are
Yeah,
using in our practices. It's one of the fantastic kits to be actually used in, especially when you have a D4 type of a bone. I think,
exactly.
and yes, that's super. Okay, so which
By the
in the
way, I have a huge team with me. I have Dr. Ekram, he's a surgeon, and I have a prosthodontist, I have an orthodontist. We are a huge team. As I mentioned, no one can know everything about everything.
absolutely, absolutely.
Yeah.
Okay, so there's another question. When we look for the impacted third molars, which one scanning you suggest should we go for? Should we go for an OPG or should we go for the CBCTs? Which one is the best as an evaluation tool? Because as when it's yeah.
Okay. Uh, First, for everything, we should make clinical examination. So if you can find the impacted tooth clinically in the patient's mouth, you can see it. So I don't think you will be in a big need for CBCT. But
Okay.
if you find the impacted tooth is not visible clinically, and you are suspecting from the symptoms that there is an impacted tooth, I think it's a must to go for a CBCT directly. And of course, for impacted canines, for orthodontists, you should go for CBCT directly.
Yes, that's right. Uh, Another question is like which of the following are considered as an essential manufacturer tool required for surgical guide fabrication?
Mm. What do you mean essential manufacturing?
Like it's
We
the
have,
CBCT machine or the optical scanner that we look into it, or a 3D printer that we look into, or a 3D facial scanners.
okay, for me, you will not, maybe the question or the doctor who submit the question will not believe me. The most important thing is the software. When I started my business, or our business, we got only the software in the beginning. We make the designs. So we were receiving the optical scan from one lab, and we were receiving the sleeves and the drills from one implant company, and then we make the 3D printing in another lab. So the most important thing is the software in the first place, and then comes anything else.
Okay. Uh, which is the digital format for the CBCT scans you recommend? Like it's the STL or the DICOM files or the PLY or the OBJ?
For the CBCT, the basic format is the DICOM. Okay, but when you go to digital dentistry, you can only convert it into STL and convert it to other type of formats. So when we try to use CBCT, most of its uses digitally is as an STL for reconstruction, but for planning, such as surgical guides or even orthodontic surgeries, mostly it is DICOM and also partly it's STL.
Okay, so which of the universal digital formats for the optical scans use talk about actually if he says the DICOM, JPEG, OPG, or the STL?
For the optical scanners, the universal format is the STL, but it has a lot of other formats like PLY, like a lot of stuff. The STL, which is the non-color format, which is recognized by all the other CAD softwares.
Okay, so I think so we have these many questions which were there, and let me see if I have another more questions coming up. I think we have little more questions, so I think people can connect you on that. So I think that will be better. So you can answer them on once they put you the query. And thank you so much, Dr. Khalid,
Thank
for
you very much.
spending your valuable time with us at the Podina Summit. And I would like to thank all the listeners all across the globe who have been here and they are spending their valuable time learning with us. And as the chairman of the International Cooperation Committee of the Global Summit, I thank you one and all, and especially to our speaker of the day, Dr. Khaled EKram, all the way from Egypt,
Thank
for
you.
sharing his valuable time and experience about the 3D scanning. I think that's one of the tools that we are looking at in 21st century endodontics, which will going to change the world of dentistry, and also in terms not only in endodontics, I say in terms of the implantology and digital smile designing. So everything is becoming a part of three-dimensional imaging. So thank you so much, sir. We are very
Thank
honored and
you.
blessed to have you with us, and we are looking forward for future to see you with us at the more sessions along with us. Thank you so much.
Thank you, and the pleasure is mine to be with you today in the Podinar, and of course with all the audience there. And I hope my lecture was informative and simple to them.
Yes,
And
it was
we
very well explained. The best part is that you have taken care of all the clinical aspects in a very crispy form, like what we say as it has to be crisp and to the point, and that makes things simpler, especially when we talk about three-dimensional imaging. I think that is one thing which people want, that they become much more simpler. So thank you once again, and have a good night, because it's, I think what's the time must be around, I think 10 o'clock, 10,
yeah,
10:30. So I'm in India. It's about 12:30 midnight. So thank you so much
okay.
once again,
Thank you. Thank you
and
very much.
have a great day tomorrow. Thank you so much. Bye bye.